if you can start the recording. Yeah, yes, okay.
Yes. So I think I'll restart. So I thank everybody for joining us. So this is the third of the program of the IPS Pharmacotherapy Subcommittee. I'm thankful to Dr. Tirthankar Dasgupta, who's a convener, Dr. Rajesh Dhume, who's an advisor, and Dr. Kaushik Chatterjee, who's the EC coordinator. Also thank Dr. N. Raju, who's the president of IPS, Dr. Vinay Kumar, vice president, Dr. Arvind Guma, honorary general secretary, Dr. Siddiqui, Aleem Siddiqui, honorary treasurer, and Dr. O.P. Singh, the editor. So I think we are doing very fine. So all the topics have been very carefully selected, and it makes a lot of clinical relevance to whatever we've been trying to do. So today's topic is psychotropics and hyperprolactinemia. I'll ask my moderator to introduce it. But subsequently, over a period of time, next couple of sessions, we are planning to do something about psychotropics in autism spectrum disorders, psychotropics and attention deficit hyperactivity disorder. So
Dr. Manu, we can't hear you. You have been muted.
just a minute. Is it fine now?
Yeah.
Was I being heard a bit before,
Yes,
or I
yes.
should repeat
Yes,
everything?
Just last 5 seconds.
Okay, that's fine. So melatonin in psychiatry is one possible topic which we are planning to do in a subsequent next month or possibly next month. So today's topic is very relevant because I think that makes a lot of clinical sense to people who practice. It's a lot of complaints. Sometimes we are at a fix what to do next. I'll hand over our mic to our convener, Dr. Tirthankar Dasgupta, will be taking over from now. Thank you. Dr. Tirthankar? Then probably I'll ask the moderator to take over then.
Thank you, sir. Wonderful opportunity. Great being on the same screen with all of you wonderful people. Look forward to a wonderful academic program ahead of us. Before we begin, I'd like to thank the office bearers from IPS who have enabled this program. Like Manu sir already mentioned, the respected president, vice president, treasurer, the respected editor, and we also had the past president, Dr. Gautam sir, a little while back. A big thank you to all of you. I'd like to request the IPS office bearers, if you are in the meeting, to kindly speak a few words. Dr. Raju sir, if you are here with us, we'd like to hear from you before we go into the academic program. Also Siddiqui sir, the office bearers from IPS, we'd request the office bearers to kindly present a brief introduction to the program before we get underway. Okay, then, like Manu sir very rightly pointed out, a very pertinent topic, hyperprolactinemia. We'll be talking about the dopamine pathways here, and although most of the focus is on the mesolimbic pathway, which we know is responsible for the positive symptoms of schizophrenia, mesocortical pathway, which are responsible for both the negative symptoms as well as the cognitive symptoms, and the nigrostriatal pathway, which is responsible for the movements and Parkinson's disease. But our focus for today will be thank you, Vinay Kumar sir, for joining. Good evening, sir. Good evening. Thank you so much, sir, for joining. Just if you could please bless us with a few words before we get started with the academic program.
So I think I'm the lone office bearer from IPS. Dr. Brahma, Dr. Raju, nobody has joined. Good evening, everybody.
Good evening, sir.
Good evening, sir.
I'm delighted to be part of this very important scientific meeting. I was facing difficult times in last few days after returning from Jaipur, where I was for many of us were there for this clinical practice guidelines. 2-3 of us got high fever. NN Raju is sick, myself, Alim Siddiqui, Gautam Saha. So something happened in Jaipur and we all fell sick. I'm little better today. So I have not seen even the topic which is going to be presented. I just hope I'm trying to open my phone and see. So anyway, I'm not the speaker. I'm here. My job is to welcome all of you, especially the task force committee and the speaker of the day, Dr. Jagjot Singh.
Thank you, sir.
Hyperprolactinemia, I think you're going to talk about. Hyperprolactinemia.
Psychotropics and hyperprolactinemia.
Yes. So hyperprolactinemia is a very rare thing. I remember just after seeing hyperprolactinemia layer, I just remember that very long time back I read somewhere in some paper. I don't remember. It was time when amisulpride was being launched in India, especially Solian. So there was small brief report that if serum prolactin level is low, the response with amisulpride is better. I do not know. There was some kind of case report. I asked to many people, nobody was knowing. I had lost link where I read it. Sometimes you keep reading something and you encounter something, comes to your mind and then you forget. When things are required, comes from your mind. So that was the situation. Anyway, so I think Jagjot Singh will be able to enlighten us much more. Hyperprolactinemia, prolactinemia is a big problem with especially amisulpride and risperidone. Amisulpride, I think yesterday, 3-4 days back, I stopped amisulpride of a patient because family was very annoyed that not having restoration, and she's a young lady, will be married in 1 or 2 years, and you are spoiling life and something. I planned to change gradually still, but symptoms recurred. It was very difficult to manage. So sometimes drugs are so important. Drugs suit some patients to the extent that they recover very well, start recovering very well, and suddenly you change, or even you gradually taper off or put on some other drug. Result is not the same. So these are very difficult clinical situations. I hope from the treasure of knowledge, Jagjot Singh will be able to enlighten us more, and we will be more comfortable in managing the cases related to that. So with these few words, I welcome the speaker and thank the task force team for organizing such an important program. Thank you very much. I will be here listening you, sir. I will not go away.
Thank you so much, respected Vice President Vinay Kumar sir, for your pearls of wisdom.
Someone from Torrent, if you can share the slides of the moderator and chairpersons.
And good evening to.
I was out of the connection before, so I couldn't introduce our young dynamic moderator, Dr. Himabrata Das. I'm very sorry for it because I got disconnected for a few minutes initially. Just make it full screen. Someone from Torrent, please make it full screen. I'm not able to see the entire screen. Are you able to see, Dr.
Yeah, it is in full screen.
I can see the full. I can see the slide.
Okay, fine. Yeah, I'm just zooming it. Okay. Dr. Himabrata Das is from Assam. He's the Assistant Professor, Department of Psychiatry, Jorhat Medical College and Hospital. He's done MD Psychiatry from Silchar in 2014. He's the Executive Postgraduate Diploma in Hospital Administration from Tata Institute of Social Sciences in Mumbai. He has a lot of extracurricular interest, include cricket, commentary, conducting quizzes as quiz master, contributed stories pertaining to diverse topics to various web portals and online platforms. Launched the online platform on Doctors Day 2020, aimed at promoting positive mental health in the wake of COVID pandemic. So he's a very young, dynamic faculty from Assam. Over to Dr. Himabrata. Now, Mike is over to you, and you conduct the session. Thank you.
Thank you so much, sir, for that kind introduction. We were discussing, the pathway of dopamine that we will focus more on will be the tubero-infundibular pathway, of course, that connects the hypothalamus to the pituitary, and how dopamine inhibits prolactin, and what is the interaction, and how it affects clinically. Four questions that our respected speaker will look to address. What is this phenomenon of hyperprolactinemia? How does it actually happen? And when and what can we do as clinicians to tackle this baffling clinical dilemma, just like our respected Vice President mentioned at the very beginning. We are blessed to have two outstanding chairpersons for this session. Can we have the slides up on the screen, please, as I'd like to take the opportunity to introduce our respected chairpersons for this evening. Dr. Gulbahar Singh Sidhu, sir, joins us from Jalandhar. Sir is a consultant psychiatrist at Doaba Multi-Speciality Hospital, Jalandhar, Punjab. He is the Vice President cum President-elect Punjab and Chandigarh branch of the IPS. Sir is also a member of the Executive Council of the IAPP and a member of the Executive Council IPS Northern. A warm welcome, sir. Great to have you on this program. And our second chairperson for the session is Dr. Deepayan Sarkar, sir. He joins us from Agartala. Can we have the slide, please?
Someone from Torrent, if you can share the slide of Dr. Deepayan Sarkar.
Sir, it is
Mr. Chandan, please do the full screen, please.
From MGIMS Wardha. He holds a fellowship in psychosexual medicine from JSS Medical College. He is currently associated with the Modern Psychiatric Hospital at the capital of Tripura, which is Agartala. He is an EC member of the IPS Publication Subcommittee. He is former Honorary Secretary, IPS Tripura State Branch. He is also conducting the responsibility of Nodal Officer, Addiction Treatment Facility. Sir's areas of interest include addiction and psychosexual medicine. With that, we come to the end of the introductory part of today's program. I'd like to request the chairpersons to...
Sorry, Dr. Himabrata, we are blessed to have Dr. Alim Siddiqui, our honorary treasurer.
Okay.
So if you can...
Good evening, Siddiqui, sir. Welcome to the meeting, sir. If you could just enlighten us with a few words before we get started with the academic program. And after Siddiqui sir speaks, the chairpersons will take over the session, and then we'll have the session on hyperprolactinemia and psychotropics. Dr. Siddiqui sir. Good evening, sir. Thank you so much for joining.
Thank you. Just in time. My best wishes, congratulations to the whole team, and especially the speaker, JJ, as we call him affectionately. JJ, all the best. All the best to Dr. Tirthan sir and all the team. Over to you.
Thank you so much, sir, for your nice words. Over to the chairpersons then. Look forward to a fantastic session. Thank you.
Yeah, good evening, everybody. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. We have a very important topic today for discussion, and I'm very thankful that I've been given the opportunity of chairing the session. And it's a topic which is of great relevance to all clinicians working in the field of mental health, because so many medicines, so many of our drugs have an effect on the endocrine system, and we should all be aware of it. Like, for example, I won't take too much of a time, but yes, this particular session made me read about hyperprolactinemia. And it's so important, not just for female patients, but for male patients as well. You know, we could be overlooking so many male patients presenting to us having hyperprolactinemia. And I look forward to our speaker today, who is incidentally also has the same alumni as myself. You know, you're both graduates from the same college, you're both postgraduates from the same college. So our speaker today shares a lot, shares something with me. And one last observation, you know, this COVID pandemic has brought so many bright minds across the country on this one screen. You know, it's a great opportunity to see myself co-chairing a session with respected Dr. Sarkar sir from Agartala, thousands of kilometers away. So now over to Dr. Sarkar, please.
Yeah, thank you, sir. First of all, I thank the organizers for giving me the chance to chair this session. Indeed, the topic kept today by the organizers led by Dr. Manu Arora and his team, and especially my friend Dr. Tirthanga Dasgupta. This topic, hyperprolactinemia, is a condition which cannot be ignored in our clinical setup, clinical treatment protocol, and at the same time, we cannot accept also. As we have seen that a large number of patients, like in India and throughout the globe, they are in a reproductive age group, and they are definitely suffering more. And not only that group, but others like elder or younger group also, they have many difficulties with the treatment, like bone density and all. And I think from the slides of our respective speaker, we'll be able to know more. And what I feel that we are lucky here today that we have our eminent speaker to discuss its various effects and ways to how to overcome this situation. And definitely we should maintain the benefits to the patient also. And today we have a respected and eminent speaker with us. He is Dr. Jagjot Singh. He is the consultant psychiatrist. He did his graduation from GMC Patiala and MD from DMC Hospital, Ludhiana. Currently, he is working in Fortis Hospital, Ludhiana, and his special interest of areas, they are like adult and perinatal psychiatry, and of course, liaison psychiatry. So without losing much time, I'll request our speaker, Dr. Jagjot Singh, to start his presentation. Thank you.
Thank you, sir. Thank you so much. So, I'm sharing my screen. So I hope the screen is visible.
Yes, it is visible, sir.
Yes, sir.
It is visible.
Yes,
Very
good.
All right. Thank you so much for the invitation, especially to all my seniors. I think all of you are. I'll begin with the topic of hyperprolactinemia. I'll be discussing its association with the current psychotropics that we are using, the earlier ones which were used, and how this hormone, or what's its role, how it affects our health, it increases, especially drug-induced pattern. We all know there are other causes of hyperprolactinemia, such as pituitary adenoma, for which we get the investigations done, and then we find out, okay, this, and then we refer the patient to this required department. But what about our field and how important this topic is for us? I hope my voice is audible. Shall we proceed?
Yeah, sir, from the audience, there is a request to raise the voice, or there is some, it's coming very low, sir. So
okay,
can you improve it a little bit?
I'll try and speaking a little louder. Is it fine now?
Yeah. Yes, a little bit, sir.
Ji. So prolactin, let's see what prolactin regulates. Prolactin secretion from lactotrophs in the anterior pituitary regulated by dopamine. I think it's already been told that dopamine has some sort of relationship with prolactin. ये रिलीज कैसे होता है? ये रिलीज होता है हाइपोथैलेमिक डोपामिनर्जिक न्यूरॉन्स, वहां से इनटू द हाइपोफाइजिल पोर्टल ब्लड. अब इन दोनों का रिलेशन क्या है? डोपामीन इज इनहिबिटरी टू प्रोलैक्टिन. डोपामिन बढ़ जाएगा तो प्रोलैक्टिन कम हो जाएगा. अगर कोई दवाई डोपामिन कम करेगी, such as our psychotropics, then it can increase the level of prolactin. So it has an inverse relationship. Other conditions such as suckling inhibits hypothalamus. It allows the levels of prolactin to be raised. Other stimuli include sleep, sex hormones, orgasm, and stress. सीरम प्रोलैक्टिन के लेवल्स की अगर बात करें तो क्या ये सेम रहते हैं, चेंज होते हैं? लेट्स सी. एंड क्या जेंडर में भी इसका कोई डिफरेंशिएशन है? So serum prolactin levels over 24 hours in healthy men and women are projected in front of you. इसमें आप clearly देख पा रहे हैं कि as the sleep time comes, the levels go a little higher and the levels are much higher in women. So prolactin secretion is pulsatile. The number of pulses in one day is around 12 to 29, both men and women. However, the amount of prolactin per pulse is significantly higher in women, as you can see from the graph. ये जो raised level है or the higher level with respect to the other gender is more prominent during the REM part of the sleep. Now, what causes hyperprolactinemia? We all know there are causes such as drug-induced or pharmacological. उससे पहले देखते हैं भी और कोई चीज है जो प्रोलैक्टिन को बढ़ा सकती है, अगर है तो वो क्या है? So first of all is physiological. Ovulation हुई है, patient pregnant है, आपको अगर नहीं पता पर उसका प्रोलैक्टिन बढ़ा हुआ है, this could be one of the reason of hyperprolactinemia. Obviously we can think patient मान लीजिए psychotic है, आपने antipsychotic डाला हुआ है, प्रोलैक्टिन raised आ गई, and then you find out कि हम ये वाला antipsychotic शायद इतना नहीं करता प्रोलैक्टिन का level, he still has the patient is a young female of a reproductive age group and has hyperprolactinemia. Getting a UPT would be a good idea, or asking the patient whether they have been trying for pregnancy. Breastfeeding, well, that's a phenomenon which is quite obvious. Stress, this is one part of my presentation where I'd be focusing कि stress से भी prolactin बढ़ता है. To an extent कि अगर venipuncture जब कर रहे हैं sample देते वक्त, अगर वो puncture ज़्यादा painful है, stress causing है, so there will be fluctuation of prolactin levels in the result. To an extent, if the patient has had some sort of exercise, even sexual intercourse before giving the sample, it can change the level of prolactin, can raise the level of prolactin. Now, exercise and nipple stimulation or chest wall injury. Pathological causes would include one of the most common pathological cause of raised prolactin is prolactin secreting pituitary adenoma. Now, pituitary alone can cause hyperprolactinemia. At the same time, अगर which we call the stalk effect, अगर सेला जिसमें पिट्यूटरी बड़ा होता है, अगर उसमें कोई और मास है, लीजन है, तो वो पिट्यूटरी की स्टॉक को कंप्रेस करेगी and it will lead to the stalk effect leading to increased level of prolactin. ये दोनों चीजें हमें MRI पे पता चलती है. कौन सी MRI we'll discuss. Now, if in our practice when we observe patients of renal failure जो dialysis से आते हैं, हम antipsychotic डालते हैं, तो उससे prolactin बढ़ सकता है. Having said that, renal failure itself raises prolactin level. Liver cirrhosis itself raises prolactin. Sometimes in cases of hypothyroidism, primary hypothyroidism we are talking about, prolactin बढ़ सकता है. इसके लिए prolactin कम करने के लिए अपन को दवाई देने की जरूरत नहीं है. Just treat or refer the patient to the endocrinologist for treatment of primary hypothyroidism. वो correct हो जाएगा, prolactin खुद ब खुद normal पे आ जाएगा. Other causes include PCOS, again in young females if you have raised prolactin. Also, if you have other symptoms of PCOS, don't forget this diagnosis. Seizures. I think we all know that to differentiate its whether it was an epileptic episode or a non-epileptic seizure as they call it, which in our case is conversion symptoms or dissociative phenomena. This is one factor that can differentiate. It's not that very sensitive and specific, but अगर अभी seizure हुआ है and within few minutes आप sample लेके lab में भेज देते हो, prolactin levels raised आते हैं, तो this was a true seizure. Pseudo seizures में इतना common नहीं होता, उतना ज़्यादा level जो है वो raise नहीं होता जितना seizure में है. Now let's come to the pharmacological aspects which cause hyperprolactinemia. First and foremost would be antipsychotics or neuroleptics. इसमें जो first generation antipsychotics थे वो सबसे ज़्यादा करते थे. जो एटिपिकल्स आए वो कम करते हैं, बट उनमें अगर आप देखिए सबसे ज्यादा करने वाला दैट इज एमिसल्पिराइड. That there was a patient of amisulpride who had raised prolactin levels, symptomatic hyperprolactinemia. That was with the amisulpride. And the second notorious drug widely known as risperidone. At higher dosages, it can raise prolactin to a level that जो prolactinomas में adenomas में जो level of prolactin मिलता है, sometimes it can reach that level, which is around 200 to 300. Now, antidepressants are not very frequent, modestly, or sometimes they don't cause. One drug, if I say, is notorious, that is clomipramine among the TCAs, although TCAs SSRI से कम cause करते हैं. SSRIs में, I think we all know that fluoxetine and sometimes other antidepressants such as venlafaxine can cause. Mirtazapine से बहुत नामात्र होता है. Antiemetics, domperidone, metoclopramide, ये दो दवाइयाँ हैं जिससे प्रोलैक्टिन बढ़ सकता है. तो अगर कोई पेशेंट पीपीआई ले रहा है लॉन्ग टाइम से और आपके पास आया and you find out there is raised prolactin, so then if I quote the data, then 50% of the people who use PPI, they also have raised level of prolactin. Now opioids, now this history patient ज़्यादातर reveal नहीं करता होता substance abuse की, but opioids in any form can increase the level of prolactin. Antihypertensives also, कौन से verapamil can increase, reserpine can increase, which is taken from the root of our Indian original plant, जो इसको हम सर्पगंधा के नाम से जाना जाता है, से मिलता है reserpine, used for, has been and sometimes still used for treatment of psychosis. It also has an antihypertensive action. Now, अब ये तो पता चल गया इन चीजों से एंटीसाइकोटिक से hyperprolactinemia हो सकता है. Now, the most important part is how much, what percentage are we talking about? If I as a psychiatrist have to choose for a patient of psychosis, मैं क्या choose करूँ? Molecule choose करूँ. उससे कितने % होएगा? Let's say the patient comes, the doc, because of your medication, I have gynecomastia or I have amenorrhea, मेरे को periods नहीं आ रहे, मेरा weight gain हो गया, and I'm not happy with the treatment. And let's say that the patient is on aripiprazole. So what should be your answer? Let's say your patient is on clozapine. What should be your answer? Or let's say you're giving olanzapine and quetiapine and they ask it, sir, इससे वो वाला problem तो नहीं होएगा? अगर होएगा तो कितना होएगा? So this is a very simple slide I kept to answer this specific question. So typical से बहुत होता है. कम होता है किससे? Less than 25% with loxapine and pimozyme. Earlier widely used, now also used, but very less. Now atypical से अगर आप कहें कि आप safe side चलना चाहते हैं, तो this is aripiprazole, clozapine and ziprasidone. Less than 25% of the patients, I'd say olanzapine and quetiapine. So if you go for pines or peens, you are a little safer. But if you go for pride and loans, then you have to think twice, because amisulpride causes the maximum amount of hyperprolactinemia amongst the antipsychotics, the atypical ones. And sitting next to it is risperidone, again very important. Then we have sulpiride or levosulpiride, जो again PPIs में add किया जाता है with the L letter, that can also cause increased level of prolactin. Now skipping to the antidepressants, उसमें TCAs जो है वो SSRI से कम करते हैं. Almost no significant raised level of prolactin is with nortriptyl. Less than 25% with the rest of them. More than 50%. If one drug you have to remember among TCAs is clomipramine, अगर आपका patient ये ले रहा है, तो chances of raised prolactin are more. Then we have the MAO inhibitors. Then we have the antiemetics. Antiemetics, as we have discussed, domperidone, that is the D component in the PPIs, and metoclopramide, quite widely used as an antiemetic, also causes hyperprolactinemia. Antihypertensives में verapamil, reserpine, and methyl-dopa. So methyl-dopa, dopamine analog, can cause increased prolactin levels. Clinical presentation. Clinical presentation दो में मैंने divide करी है. One is the women's and the second section is of the men's. Now we'll be focusing on the premenopausal women because उससे range अलग होएगी और postmenopausal में अलग होएगी. Premenopausal women, marked prolactin excess more than 100 is commonly associated with hypogonadism, galactorrhea, and amenorrhea. जब आप कोई पेशेंट को टेस्ट लिखते हो सीरम प्रोलैक्टिन, तो जो उसकी यूजुअली जो इंडियन लैब्स रिजल्ट दिखाती है वो इस यूनिट में दिखाती है, दैट इज माइक्रोग्राम पर लीटर और नैनोग्राम पर मिलीलीटर. इट्स द सेम थिंग. अगर 100 से ज़्यादा है तो ये पेशेंट, ये मार्क प्रोलैक्टिन है. ये यूजुअली वो पेशेंट्स होते हैं जिनका प्रोलैक्टिनोमा निकलता है, जिनके एमआरआई में एडेनोमा आता है, तो इनको हाइपोगोनाडिज्म, दैट इज इनफर्टिलिटी, सेक्सुअल डिसफंक्शन, गैलेक्टोरिया के सिम्टम और एमेनोरिया के सिम्टम बहुत प्रोमिनेंट. मॉडरेट प्रोलैक्टिन लेवल माने 51 to 75 वाले, they are associated with oligomenorrhea. Mild prolactin excess 31 to 50 is also associated with short luteal phase problems, decreased libido and infertility. Increased body weight may be associated with prolactin secreting pituitary tumor. याद रखिए प्रोलैक्टिन अगर ज्यादा देर तक बढ़ा रहेगा तो वेट भी बढ़े. ओस्टोपेनिया, अगर हम कहें कि हम यूजुअली एज डॉक्टर्स वी फोकस ऑन शॉर्ट टर्म मैनेजमेंट ऑफ प्रोलैक्टिन. चलो प्रोलैक्टिन बढ़ा है तो ये सेक्सुअल प्रॉब्लम्स आएंगी या इनफर्टिलिटी की दिक्कत आएगी या मेंस्ट्रुअल प्रॉब्लम्स आएगी, बट वी यूजुअली ओवरलुक, वी डोंट टेक द लॉन्ग टर्म साइड इफेक्ट सीरियसली, व्हिच इज ऑस्टियोपेनिया और ऑस्टियोपोरोसिस. these patients become prone to fractures after decades. तो इनमें अगर आप पेशेंट को लॉन्ग टर्म दे रहे हो और प्रोलैक्टिन का बड़ा रह रहा है, then you might need to treat osteopenia or osteoporosis as well, which would be a wise move. Degree of bone loss is related to the duration and severity of hypogonadism. So you can correlate because that is correlated with the level of hyperprolactinemia. Amongst men, symptoms would be decreased libido, impotency, decreased sperm production, infertility, gynecomastia, and rarely galactorrhea. Men में galactorrhea इतना commonly नहीं देखा जाता. Impotence is unresponsive to testosterone treatment and is associated with decreased muscle mass, body hair, and osteoporosis. जब हाइपरप्रोलैक्टिनेमिया हो या ड्रग इंड्यूस्ड में हो और आपको देखिए कि टेस्टोस्टेरोन लेवल्स कम हैं, सप्लीमेंट करने से उससे कुछ ज़्यादा फायदा नहीं हो. सो द हार्मोनल स्ट्रैटेजी इज नॉट वाइडली यूज्ड. अब आपने पेशेंट को बोला है कि जी आप अपना प्रोलैक्टिन लेवल जो है वो चेक कराइए, उसका जो ब्लड सैंपल देना है वो कब देना चाहिए. करंट गाइडलाइन से सीरम प्रोलैक्टिन कैन बी विड्रॉन एनी टाइम ऑफ द डे. जो चीज़ का आपने ध्यान रखना है कि उससे 30 मिनट्स लिखा है, वी यूजुअली एडवाइज 1 hour, no exercise, nipple stimulation, any stressful workout should not be there. Typically normal prolactin is less than 20 in men, less than 25 in women. However, it is important to interpret the results according to the assay, जो lab range है उसके according. A single PRL value above the upper limit can be sufficient for the confirmation, provided that the blood sampling took place without excessive venipuncture stress. Some guidelines even suggest that instead of doing a puncture right there, आप एक कैनुला लगाइए, आराम से पेशेंट को रेस्ट करने दीजिए, उसके बाद सैंपल दीजिए, so that stress does not come into it. And obviously, if there is a doubt in cases of mildly elevated prolactin, सैंपल को रिपीट करवाइए. आपको जब लगे ना कि ये रेज्ड है लेकिन उससे पहले ये चीज़, वो सर उससे पहले तो हम ये कर रहे थे, यहाँ गए थे, ये चीज़ हुई थी, बेबी को अभी फीड करके ही हटे थे, तो आपकी एक फॉल्स रीडिंग आ सकती है. जस्ट टेल द पेशेंट टू रिपीट एंड मिनिमम 30 मिनट्स दे शुड बी रेस्टिंग. बायोकेमिकल इंटरप्रिटेशन, तो अगर एक चीज़ मैं आपको बोलूँ कि इंटरप्रिटेशन में कोई दिक्कत आ सकती है, मान लीजिए पेशेंट को सिम्टम्स कोई नहीं है और लैब के रिजल्ट्स में प्रोलैक्टिन बढ़ा हुआ आया, तो इस चीज़ को याद रखिए, दैट इज मैक्रोप्रोलैक्टिन. ज़्यादातर जो सर्कुलेट होता है प्रोलैक्टिन, दैट इज मोनोमेरिक, दैट इज 23 किलोडाल्टन. इससे बड़ा भी होता है, दैट्स कॉल्ड बिग प्रोलैक्टिन, 45 to 60 किलोडाल्टन. इससे भी बड़ा प्रोलैक्टिन का एक यूनिट होता है, दैट इज बिग प्रोलैक्टिन, पॉलीमेरिक प्रोलैक्टिन, 150 to 170 किलोडाल्टन. मैक्रो प्रोलैक्टिन मोस्टली कॉम्प्लेक्स होता है, प्रोलैक्टिन का IgG के साथ, प्रोलैक्टिन का IgA के साथ, या पॉलीमेरिक एग्रीगेट्स. इन मोस्ट इंडिविजुअल मेजॉरिटी जो है वो मोनोमेरिक ही मिलेगा, बट इन अदर्स मैक्रोप्रोलैक्टिन ज़्यादा होता है, लीडिंग टू मैक्रोप्रोलैक्टिनीमिया. अब ये कंफ्यूजन ना हो, आप इसको हाइपरप्रोलैक्टिनीमिया ना समझ लें. अगर सिम्टम नहीं है, रेज्ड है, और आपने टेस्ट आगे कराया कि देखना यार ये मैक्रोप्रोलैक्टिन तो नहीं है, उन्होंने कहा नहीं सर ये मैक्रोप्रोलैक्टिन के लेवल्स हैं, तो ये इनकरेक्ट डायग्नोसिस हो जाता है. सो व्हेनेवर यू हैव दिस काइंड ऑफ रिपोर्ट, टेक केयर. Okay, biochemical interpretation. Hook effect क्या होता है? This is one effect which I want you to remember. आपने पेशेंट देखा, पेशेंट को सारे सिम्टम्स हैं क्लिनिकली, आपको लगा यार हाइपरप्रोलैक्टिनेमिया के सिम्टम्स हैं। लेट्स से आपने एमआरआई का भी बोल दिया, उनका कोई एडेनोमा निकला है, मैक्रो एडेनोमा आया, प्रोलैक्टिन लेवल जो है वो बहुत कम है, माइल्डली रेज्ड या इवन लो, तो दैट रेजेस सस्पिशन। अब ये कैसे हो गया? इट्स कॉल्ड द हुक इफेक्ट. It is encountered in the presence of excessively high PRL level which saturate the antibodies. और जब रिपोर्ट आती है, because antibodies are all saturated, उसमें जो फ्री है वो लो आता है PRL level. A failure to recognize this effect is missing the diagnosis of a prolactinoma. तो अगर आपने ये मिस कर दिया, literally the patient can sue you. I had a small adenoma, or I have, इनकी भाषा में I had a brain tumor, and doctor, you didn't advise me anything. Now imaging. इमेजिंग में पिट्यूटरी बोलनी है जब भी आपको डाउट है. मान लीजिए आपने फिजियोलॉजिकल कॉजेज रूल आउट कर लिए, आपने थायराइड नॉर्मल है, रिपोर्ट चेक कर लिए, ड्रग इंड्यूस में आपने कॉजेज देख लिया, आपके पास पहली बार पेशेंट आया, देखा भी कोई एंटीसाइकोटिक नहीं चल रहा, बट उनके पास एक प्रोलैक्टिन की रिपोर्ट है, उन्होंने बाकी हार्मोनल टेस्ट में करवाई थी. गो फॉर अ पिट्यूटरी एमआरआई, एंड इफ यू आस्क फॉर द गोल्ड स्टैंडर्ड वर्ल्ड वाइड अप्रोच, इट इज एनहांस्ड विद गैडोलिनियम. Remember, जब भी आप एक डाई देते हैं such as gadolinium, there is a risk of systemic sclerosis. This is a brief algorithm कि आपको क्या करना चाहिए. आपको अगर रिपोर्ट लगे कि हाइपरप्रोलैक्टिनीमिया है बट आप डाउटफुल है ये, तो पहले यूपीडी करवाइए अगर रिप्रोडक्टिव एज ग्रुप में यंग फीमेल. Then you rule out the thyroid profile, primary hypothyroidism. Then you check out कि जो लिस्ट हमने डिस्कस करी उन वाले ड्रग्स हैं जो ज़्यादा कॉज कर सकते हैं. देन ऑल्सो कीप इन माइंड पीसीओ, गेट द आरएफटीज एंड द एलएफटीज डन. अगर रीनल फेलियर में है पेशेंट, सीकेडी का पेशेंट है, डायलिसिस का है, दैट इज द कॉज. सिरोसिस का है, दैट इज द कॉज. यू कैन ऑलवेज टॉक टू द पेशेंट. देयर आर अदर फैक्टर्स इन दैट. ओके, एंड व्हेन एवरीथिंग इज नॉर्मल एंड यू स्टिल हैव रेज्ड लेवल, go for a pituitary MRI to rule out a prolactin secreting tumor. And remember the hook effect. Okay, अगर आपने इलाज करना है, प्रोलैक्टिनीमिया ठीक करना है, तो आप कौन सी चीज ठीक करना चाहते हैं? आप दिमाग में होनी चाहिए. एक, रिस्टोरेशन एंड मेंटेनेंस ऑफ नॉर्मल गोनाडल फंक्शन, माने मेल है चाहे फीमेल है, उसकी फर्टिलिटी पोटेंसी वो नॉर्मल होनी चाहिए. सेक्सुअल डिसफंक्शन नहीं होना चाहिए. अगर प्रोलैक्टिन रेज्ड है, सेक्सुअल डिसफंक्शन आ रहा है, so that is our goal. One, that's a short term goal which mostly we get. The part we miss is osteoporosis. So always remember, if your patient is complaining कि सर मेरा बहुत फ्रैक्चर हो गया, ट्रॉमा इतना हुआ नहीं, पता भी नहीं चला कैसे, बोन वीक हो गया, पेन्स रहती है, get it examined and treat the cause. Now, अब अगर आप प्रोलैक्टिन बढ़े हुए हैं, लाइक डॉक्टर विनय ने केस डिस्कस किया कि MSL लेट्स से आपने कोई दवाई दी, the medication has beautiful effect. You do not want to lower down, or let's say you do not want to switch. What can we do? Can we give something to lower the prolactin and treat the patient? Yes, mostly widely practiced and approved treatment is dopamine agonist, उसमें टेबरबुल. Usual dose जो होती है वो 0.5 milligram twice in a week. Is that something which is given? Although the range is 0.25 to 0.5 once weekly or divided in 2 dosages. There are other measures, other treatment modalities as well, but we'll be sticking to discussion of टेबरबुल. ये दवाई देने का एक डर जो याद रहना चाहिए, that is the so-called flaring up of psychosis. But to be very honest, अगर आपका एंटीसाइकोटिक कवर अच्छा है, पेशेंट ठीक है, that means आपका एंटीडोपामिनर्जिक कवर स्ट्रॉन्ग है, तो ये स्मॉल डोज एगनिस्ट ज़्यादा फ्लेयर कर नहीं पाएगा. If you give it and you observe, and you keep a shorter follow-up, you can maintain or lower down the levels of prolactin, keeping your choice of antipsychotic. My next agent is aripiprazole. आप पूछे कि कौन सा एंटीसाइकोटिक है, हम दे सकते हैं और ज़्यादा फिक्र न करनी पड़े, या मैं अपना दूसरा एजेंट रखना चाहता हूँ, तो क्या कोई और चीज़ है? मैं नहीं चाहता कि देना. I don't want to risk flaring up or change in psychosis. Then the agent of choice would be aripiprazole. Usually dose recommended is 5 milligram. कि अगर आप up to 5 milligram दीजिए, प्रोलैक्टिन कम होने लग जाता है, and with good results. Having said that, you can also use aripiprazole as an antipsychotic to treat that psychotic part. Just increase the dosage more than 5 and you'll have results. The same has been showed by these studies. If you look at the first study, the first antipsychotic was glopanthenol bleak risperidone. Dosage of aripiprazole was 20 to 25 milligram per day. Switch kara tha, and approximately after 4 weeks, serum prolactin levels were normal. And all patients reported improvement in their symptoms of galactorrhea and anemia. Second study अगर आप देखें, इसमें risperidone दी जा रही थी. इसमें aripiprazole ऐड कर दी गई, 5 to 20 की रेंज रखी गई थी. Significant improvement in positive and negative symptoms on PANSS. More efficacy in risperidone than benzodiazepines. Moving on to the gross management, what are the options अगर antipsychotic induced symptomatic hyperprolactinemia है, पेशेंट को सिम्टम आ गए हैं, सेक्सुअल डिसफंक्शन है, आपको ओस्टियोपोरोसिस के सिम्टम दिख रहे हैं लॉन्ग टर्म, आप कुछ करना चाहते हैं तो क्या ऑप्शन है? वन इज रिडक्शन ऑफ द डोज, सेकंड इज सब्स्टिट्यूशन ऑफ द मॉलिक्यूल विद अनदर एंटीसाइकोटिक जिसकी प्रोपेंसिटी कम है, जैसे अपन ने लैंजेपिन के बारे में बात करी, कोटायापिन के बारे में बात करी, इसकी सबसे कम है एरिपिप्राजोल के बारे में बात करी. Then is addition, as we discussed, we can add aripiprazole in the treatment guideline. Next is hormone replacement, not so affected, not really recommended. Next is dopamine agonist. Theoretically, it may be alarming, but it is not that problematic. With the use of cabergoline used wisely, can be managed. Now, I kept the description part of hyperprolactinemia very brief. I wanted things to be precise and to the point and very simple. So I'll just leave you with some take-home points. ये points अगर आप याद रखते हैं prolactin को लेके, basic चीजें, you'll be able to defend yourself. You'll be able to treat your patients in a much better way. I'm pretty sure most of you already know this. जी. So take-home points. Prolactin अगर 250 से ज़्यादा, these are highly suggestive of prolactin. अगर साइंस प्रेजेंट है बट रिपोर्ट में प्रोलैक्टिन लेवल्स लो आ रहे हैं, सस्पेक्ट द हुक इफेक्ट. जब सैंपल लिया गया है तो माइल्ड, दैट इज आई एम सॉरी आई कांट हियर यू. आर यू टॉकिंग टू मी, आर यू टॉकिंग टू समवन एल्स?
No studies is SSRI, I'm certified modest.
I guess you're talking to yourself. Never mind. So next is nearly 50% prolactin levels return to normal within 4 days of stopping the offending. तो अगर आपको लगता है ये ड्रग इंड्यूस्ड है, बंद करोगे तो roughly within 4 days it should come down. Meta-analysis of 5 recent RCTs showed a prolactin normalization rate of 79% with aripiprazole. In most studies, SSRIs have been shown to cause a modest or no increase in prolactin in treated patients, and it is even rarer with TCS, except the drug you have to remember is clomipramine. It can cause. Hyperprolactinemia is found in over 50% of the patients taking prokinetic drugs such as domperidone and metoclopramide, which is an anti-emetic. So, if patient us pe hai, you should mind that can also be responsible. Hyperprolactinemia, HPRL, is a common side effect of antipsychotics and even extend up to 70%. Mildly raised hona 25 to 100 in cases of drug-induced hyperprolactinemia is also highly variable, with the typical and risperidone levels up to even 300 nanogram per. Don't overlook the long-term outcomes of hyperprolactinemia, which includes osteoporosis. Now, when thinking of cabergoline, I want you guys to remember 2 things. One is pain abdomen. अगर आपका patient nausea, gastric discomfort, pain abdomen की complaint कर रहा है, that could be because of cabergoline. Second, impulse control disorder. आपने dopamine agonist डाला and the patient starts showing impulsivity in the form of sexual behavior, in the form of gambling, some sort of addiction. Keep a watch. Flaring up of psychosis may not be as big a problem as we think, as long as antipsychotic, a proper antipsychotic cover is there. A recent network meta-analysis also compared the efficacy of aripiprazole and metformin on reducing prolactin, which suggested that adjunctive aripiprazole less than 5 milligram per day was the most effective. In short, before diagnosing it as drug-induced hyperprolactinemia, please do not forget suckling, stress, sex, DPIs, PCOS, pregnancy and prolactinoma, thyroid functions, renal function, and liver function. Thank you so much.
Thank you, Dr. Jagjot. Wonderful presentation, and people in the audience are appreciating your comprehensive presentation. Just like to summarize for the benefit of our viewers. Dr. Jagjot started with the physiological, pathological, and pharmacological causes of hyperprolactinemia, with special mention for amisulpiride, clomipramine, risperidone, long-term PPI use. In fact, there's a question in the chat box as well pertaining to this. Verapamil is one of the agents that you mentioned. Very nicely discussed the clinical presentation in perimenopausal women and in men, depending upon the blood prolactin levels, mild, moderate, and marked, the three ways of dividing the presentation. Blood sampling, that is something that most of us would not have been too aware of. Also, macroprolactin, which might be vexing diagnostic problem. The Hookie effect, something that was very interesting, I found, and imaging, of course. A very simple, lucid diagnostic algorithm that doctor has presented, and then the treatment goals, what we can do as psychiatrists, and when do we need to take the help of the endocrinologist. Coming to the treatment, doctor mentioned bromocriptine, cabergoline, and quinabolide. Also spoke about the risk of flaring up of psychosis, but that's not something that we should worry about too much. The role of aripiprazole, very nicely doctor has mentioned the 4 studies which support aripiprazole, the partial dopamine agonist, and then a very nice overview of management with 2 slides containing the take-home messages for our listeners. Big thank you, Dr. Jagjot, wonderful presentation. We've got a question in the chat box, and I'd like you to respond to this, please, before I hand over the microphone to the chairpersons. So there's a question from Dr. Nachiketa Desai asks, hello Jagjot Bhai, excellent presentation. A practical query. A patient on psychotropics from our side and on anti-DM, anti-hypertensive meds, also a PPI plus prokinetic from physician. Physician is now blaming it on our meds, not ready to reduce his. Has ever any patient told you that it's due to psychotropics? How do you go about it? Dr. Jagjot, your take on this question?
Well, one thing that we should be very clear that our psychotropics, especially antipsychotics, can cause hyperprolactinemia. And if there are other agents and there are psychotropics, then they have an accumulative effect on raising the level of the levels of prolactin. So it's not a question of re-answering or telling the patient, it's the question of treating the problem, right? So अगर prolactin बढ़ा हुआ है तो discuss with the patient. We have these 2 modalities roughly. आपको लगता है ये सारी दवाइयाँ हम बंद कर सकते हैं? नहीं, तो मैं कोई चीज़ ऐड कर देता हूँ जिससे आपके prolactin levels कम हो जाएंगे. Patient psychotic है and prolactin बढ़ा हुआ है, चाहे multiple medication के कारण, add a little bit of aripiprazole and you'll be surprised to see the effect. Prolactin levels इतने अच्छे नीचे आने लग जाते हैं. And if the patient does experience some side effects with aripiprazole, such as akathisia, inner restlessness, वो कहते हैं कि बेचैनी बहुत बढ़ गई है, मैं ये दवाई नहीं खा सकता. So then you can think of adding cabergoline, given in a dose, let's say 0.5 milligram twice a day, can be managed. One thing which I always, or one message I'd like to add with today's presentation is, you have to share or disclose certain side effects with the patient. The current discussion going on in the world is कि अगर 10% से ज़्यादा होता है एक side effect की prevalence या incidence, you have to tell the patient. Because if you don't, and they go to the court and they sue you, कि देखो आपने किया तो gynecomastia हो गया, infertility बच्चा नहीं कर पाए, आपने हमें बताया नहीं कि आपकी दवाई से हम खाते हैं. तो first tell the patient this can happen. सिंपल भाषा में बोलूँ, देखो माहवारी रुक सकती है, दिक्कत आ सकती है, पर घबराना मत, ये रिवर्सेबल है। तो आपने बता भी दिया, आपने ये भी बता दिया कि बंद करेंगे ठीक हो जाएगी। और ऑल्सो टेल द पेशेंट कि जब अगर ज़रूरत पड़ी तो हमारे पास इसको ठीक करने की भी मोडालिटीज़ हैं। तो अगर आप रिस्क बेनिफिट रेशियो देखें तो मैं आपका इलाज करना चाहूँगा पहले, फिर मैं इसको भी ठीक कर सकता हूँ। नाउ इवन द कॉन्फिडेंस ऑफ द पेशेंट। सेकंड, all the conversations happening in the room does not matter unless you've written it on the prescription, right? तो आप पर्ची के नीचे side effects explain to the patient. That's a blanket statement, but try telling the patient कि ये हो सकता है. I think that will solve the problem in the coming future as well. Because day by day patients को जब वो देखते हैं कि अच्छा रिस्पेराडोन डाली, अच्छा इससे तो ये भी हो सकता है, हमने तो बचा करना था, आपने गड़बड़ कर दी, राइट? तो आपने पहले ही एक नोशन सेट कर दिया है कि ये चीजें हो सकती है, तो दिस इज हाउ वी आर गोइंग टू गो अबाउट इट.
That's a valid response, Dr. Jagjot. So the role of psychoeducation and also explaining to the patient the possibility of side effects plays an important role. Congratulations coming in from Dr. Siddiqui sir. Very lucid presentation. Congratulations, he says.
Thank you, Doctor.
And then you've got two quick ones from Dr. Sunny Dua. Your take on prochlorperazine, which is first generation antipsychotic. Your quick thoughts, Dr. Jagjot?
Right. I think prochlorperazine, as you rightly said, it's a first generation. I think it's Stemtel is what we frequently use it. चक्कर की दवा आती है तो Stemtel की गोली खा लो तो ठीक हो जाएगा. Right? It is antipsychotic. It can cause hyperprolactinemia. Usually हम Stemtel we give it on the SOS basis. So अगर कभी कभार दी जाती है as an anti-vertigo drug आप देते हो तो I don't think इतने levels raised होंगे because you're not giving it consistently. But if you're using it as an antipsychotic, then definitely yes.
And there's another question from Tarun D. Singh who asks if a patient is presenting with hyperprolactinemia due to an antipsychotic, for example, risperidone, so does it make sense to add aripiprazole or rather switch? So your strategy, your response to that question.
Right. So the question is switching or add-on. If the patient has responded good, let's say the patient responded beautifully to risperidone, then any psychiatrist would prefer an add-on rather than shifting. Even the patient would say कि सर अभी मैं ठीक हूँ, दवा मत बंद करिए, तो रिस्क ले लूँगा, या आप इसको अगर वैसे ठीक कर सकते हो तो कर दीजिए. I think the first move, if the patient is stable or responded good to risperidone, is to add aripiprazole low dose as an adjuvant or as an agent that can decrease prolactin levels. Whichever the choice is, I think that's a choice of the treating psychiatrist.
And there's another question also, doctor, on hyperprolactinemia predisposing to breast cancer and endometrial carcinoma.
Yes, it is. A lot of
yes. Yeah, so that's a genuine concern. And cariprazine and its role in hyperprolactinemia. What about cariprazine in hyperprolactinemia?
Right.
Does it have any role?
There was another question as a psychiatrist over long term, what is more beneficial strategy? So if this is not something which is evidence based, I'm telling, this is something which is part of my treatment strategy. I prefer adding on aripiprazole.
Okay.
Rather than adding dopamine agonist, first would be add aripiprazole. अगर patient को suit करती है, सब कुछ हल हो जाएगा. Psychosis part, mood disorder part, आप prolactin को कम करना, and without causing any weight gain. And I must say one thing from my small clinical experiences. Once you've stabilized the patient on, patient has improved on, let's say, typicals, हम उसको भी तो atypical पे shift करते हैं बाद में for the long-term continuation phase. अगर आपके एक दवाई से अच्छा असर आ गया है, prolactin बढ़ गया, तो slowly you can shift to aripiprazole and maintain the patient on aripiprazole. Frank psychosis के टाइम जितनी दवाई की जरूरत पड़ती है, बाद वाले टाइम में उतनी नहीं पड़ती.
Yeah.
You can use it of a partial agonist at that.
And you've got a question from Siddiqui sir. He asks, how do you differentiate between medication-induced hyperprolactinemia and other causes?
Right. Sir, medication-induced जो है usually mild होता है. It's not that severe. 100 के नीचे values आएंगी. Stress की भी इतनी आ सकती है. तो stress से भी हो सकता है, दवाई से भी हो सकता है. The levels decide. अगर पिट्यूटरी एडिनोमा है तो ये लेवल 100-200 से ऊपर जाने वाले हैं. इवन यू कैन इमेजिन लेवल्स अप टू 1000, इवन अप टू 10,000. Drug induced, they don't go that high. One. Second is temporal relationship. आपने दवाई शुरू करी तो प्रोलैक्टिन बढ़ा, बंद करी 4 दिन बाद आपने रिपोर्ट कराई, बिकॉज 48 to 96 आवर्स उसके बाद लेवल जो है वो 50% से भी नीचे आ जाएंगे, एंड इन 50% केसेस वो नॉर्मल पे आ जाएंगे. 4 days is the window that you have to remember. Last, I think this is a very important question because इसमें एक message था which I wanted to give. In current scenario, if you have a patient who's, let's say, a young female or a young male, आप जब ट्रीटमेंट शुरू करोगे आप एक प्रोलैक्टिन लेवल्स करवाओ. It is going to be your best defense always. वो पहली रिपोर्ट. बाद में कोई चेंज अगर पहले ही आपको थका इतना है, you can always defend yourself and your prescription. ये I think this is something which we have to inculcate in our daily practice. Could be a little tiresome, but it is very prudent these days because thanks to Dr. Google, अब हमसे ज़्यादा knowledge होती है दवाइयों की.
That's a fair enough answer, Dr. Jagjot. Another question from Muhammad Irfan. He's asking you to tell him about how hyperprolactinemia and osteoporosis are related. The answer must lie somewhere in the pituitary, right?
Right. Irfan, I'll be very honest with you. I tried studying the whole mechanism, and this mechanism can only be explained by Dr. Bhaskar or Dr. Malik. So, मैंने बहुत कोशिश करी. I wanted to include that slide also. It involves a lot of genetic framework. It involves a lot of factors which are there, and it's very complex. So इसलिए मैंने वो डाला नहीं. Basic simple मैं आपको बता सकता हूँ कि इससे जो है मेटाबॉलिक प्रोफाइल डिरेंज होता है. लॉन्ग टर्म देने से वेट गेन होता है, बोन रिजॉर्प्शन शुरू हो जाती है, ओस्टियोपेनिया हो सकता है, पेशेंट वुड बी मोर प्रोन टू फ्रैक्चर्स. तो अगर आप ये दे रहे हैं और प्रोलैक्टिन रिलीज्ड है और सिम्प्टोमैटिक है, ओस्टियोपेनिया या ओस्टियोपोरोसिस का भी ध्यान रखिएगा. इसको ट्रीटमेंट के लिए आई थिंक सजेस्टेड ट्रीटमेंट वुड बी बिस्फॉस्फोनेट्स एंड अदर सप्लीमेंटेशंस. Question about cariprazine.
Yeah, there was a question about cariprazine.
Cariprazine, I think, cariprazine is a very new drug, recently being used, but it does have a propensity to cause hyperprolactinemia. It does cause EPS. It does cause akathisia like aripiprazole. With literature-wise, I'd be able to support this fact very soon.
Okay, and there's another question on. There's another question on. I'm just missing the question. Just a second, doctor. If a patient, Dive asks, if a patient is asymptomatic and has high prolactin levels, does this require treatment?
Depend on. See, most of the time, अगर antipsychotic patient चल रहा है तो उसके prolactin levels raised होंगे और asymptomatic होंगे. Moment you have some symptoms, you go for testing. You rule out the cause. अगर prolactin बढ़ा है और उसको sexual problems आने लग गई है, irrespective male menstrual disturbance आने लगी है, then you treat it, right? Because again I'll tell you, there will be symptoms जो patient आपको बताएगा, such as fertility issues, period issues. There are symptoms जो patient नहीं बताएगा, such as osteoporosis. तो आपको एक watch रखनी है. अगर levels up to 50 है, 40-50 है, mild levels हैं, तो इसको guideline कहती है कि आप time to time prolactin levels check कराते रहिए. अगर वो ज़्यादा नहीं बढ़ते हैं, you don't need to worry much.
Good evening, Dr. Om Prakash Singh, sir, respected editor, is also joining us. He's got a question for you. Did mention clomipramine, doctor. Which SSRI causes it, and is there any difference, and why? Did you come across any SSRI?
Yes. SSRI में fluoxetine is one which is known to cause hyperprolactinemia. Mirtazapine से नहीं होता है. Trazodone से भी I think नहीं होता है. SSRIs can cause. Not very much. Literature says modest to no elevation with SSRIs, but they can cause.
And
I have highest I have found with sertraline. So is there any reason of differential between different SSRIs? I do not know why it occurs, but is there any difference between all the SSRIs?
Yes, sir, difference है. First of all, welcome, Dr. Ro. Thank you for asking the question. Difference है, there are certain SSRIs जिनसे ज़्यादा होता है, sertraline से, paroxetine से, fluoxetine से, compared to other SSRIs. Agar you want no problem with such, then I think one should switch over to something like mirtazapine. Again, it is not very common. It is not very troublesome with SSRIs. You have to account the factor of stress in such patients, differentiating whether ये SSRI से हुआ या patient को पहले से था, is getting a baseline done once the patient approaches you and you feel that it's a prospective patient in which hyperprolactinemia अगर होता है तो हमें दिक्कत आ सकती है, तो हम पहले baseline check कराते हैं.
Okay, thank you so much, OP Singh sir, for that question and a good response from Dr. Jagjot as well. Nechil Thodi has 2 questions for you. He asks, can we treat persons with compulsive sexual behavior disorder with a combination of naltrexone and prolactin raising antipsychotic like risperidone? Like that's
Okay, so
that's an interesting question, right?
I must say that's a trick question. All for that. Really sure of is naltrexone? Yes. Compulsivity अगर ज़्यादा होती है, compulsive sexual है, तो I would prefer adding. My personal choice would be adding a little bit of fluoxetine. Compulsion वो कम करके. Risperidone से, well, you can theoretically think of, but I would prefer that.
That's a very interesting question, and he's got also
the
another
literature to give a
question,
convincing answer.
Yeah, the next question is on depot typical antipsychotics like the depot preparations for flupentixol or haloperidol. Any literature, doctor, on how frequently we need to do the screening or assessment regarding bone marrow density? Sorry, the bone density, bone mineral density, and checking for masses in these patients.
Not really. Patients usually start complaining. अगर patient complain करता है कि उनको generalized weakness रहती है, body pain रहती है, sometimes patients even tell कि उनको bony pain रहती है, or they feel a mass in their breast. This is not something that we'll go for screening on a regular basis. So these are problems chronically associated, right? A simple thing would be checking the levels of prolactin. If you think they are markedly raised or suspicion है कि वो raised है, and the patient is also complaining of these factors, then you go for these screenings.
It's been an absorbing question and answer session. A big thank you to the audience as well for being interactive, and we've had some wonderful questions from eminent psychiatrists all over the country. We'll conclude with the final question for the evening. You mentioned this is a follow-up question that you have on your screen. This is from this is regarding the dose of aripiprazole. A follow-up question by Tarun D. Singh. He asked, yeah, please, your response.
Yes, I had the same question when I read the literature. Literature said कि अगर आपने कम करना है तो use aripiprazole up to 5 milligram. But that was just to lower down prolactin. Aripiprazole itself is an antipsychotic and you can use it. Go to 10, you go to 15, 20, 30 if you want to. Use it as such single-handedly if you want to. So yes, even 2, 3, 4 or 5 milligram of aripiprazole can work if you want to bring down prolactin levels. But if you have to treat the patient as in using an antipsychotic, go up. It has benefit as long as the patient is tolerating it and doesn't have significant ADRs from aripiprazole.
Thank you so much, Dr. Jagjot. It's been wonderful listening to you. I hope the audience is also really appreciated your presentation, and we've had a wonderful interactive session also. A big thank you to all the participants for your vibrant questions, and big thank you, Dr. Jagjot. Look forward to meeting you in the future. Over to the chairpersons for their concluding remarks. Dipayan sir and Sidhu sir, thank you so much, sir. Thank you so much, Dr. Jagjot.
Thank you,
Sir, I have one question for the speaker, sir. Like if there is hyperprolactinemia and if the prolactin level is raised, so if we start the agonist like evergreen and all, so how to proceed with the treatment and how to lower down the agonist therapy, and is there any specific guideline or any guideline for that one?
Right, sir. The most recommended guideline is if you want to start dopamine agonist, that is cabergoline, you start with 0.5 milligram twice in a week. एक हफ्ते में 2 बारी 0.5, or you go up for 4 to 6 weeks. And you get the levels checked again. If it has worked, it's done its job.
Okay.
But again, the question of how long would come because of antipsychotic chal raha.
And
Which I wanted to tell is that the question of flaring up of psychosis is not that, right? As long as you have a good antipsychotic.
and one observation, Dr. Jagjot,
Ji sir.
you did give a very good presentation. Of course, you need to be
Thanks.
complimented for that. But I was just wondering, why our discussion tends to overlook some drugs. For example, ziprasidone. We don't use it much. We don't talk about it much, but it's a good drug. And you yourself mentioned that it is one of the antipsychotics which does not cause hyperprolactinemia. And I really wonder, why are we not using ziprasidone that much? And that gives way to another bigger question. We can discuss it sometime else, but just want to raise it, that our discussions should not be driven by the marketing forces.
Right.
There's so many medicines which are very good, and we don't talk about them just because they are not marketed. I think there's a point to ponder for all of us.
Right. So ziprasidone is a wonderful molecule. It has very few side effects. Its usage is also very few, unfortunately, because of, I think you've already mentioned the reason. The hype with the cardiac side effects was something that scared, I think, most of us. That was when we thought कि no, जैसे clozapine से नहीं है, एक granulocytosis हो जाएगा कोई बस patient को कुछ हो जाएगा पता नहीं, as if it is very common, very common माने कि 10%. It doesn't touch 10% points में, but the fear with that factor is too much. It's still lingering inside our head. Now that's the same thing with ziprasidone that happened. The cardiac side effect profile kind of scared us कि हम use करिए नहीं. And to be honest, जहाँ पे भी ziprasidone use करी है, I never counted that side effect, and it is a wonderful molecule. And you're very right when you pointed it out. We should use it more often.
So I think we are very near to the to end of the session. And before closing this session, actually, I just want to thank all the participants, because I saw around 70 participants were there. So it's a huge number. So credit goes to this subcommittee, and I must congratulate Dr. Tirthankar and Dr. Manohar and his team. So, and we have seen that many of our IPS bodies, senior persons and senior members, senior colleagues, faculty members were present. And from my side, I thank all I thank the speaker and moderator. He moderated Dr. Himabrata very well, and you have taken all the questions so nicely, and you have given your comment. You have seen that you have respected the seniors also over here. So from my side, I hand over the mic to another respected chairperson, sir. Sir Gulbhar Singh, if you want to comment anything, sir.
It's a very good presentation and a very stimulating session. And I thank all of you for joining us today. Thank you.
Thank you, sir. Thank you, Dr. Sidhu. First of all, thank you, everybody. I think the speaker has done a wonderful job. I think that is the role of a clinician, to make it precise, make it sensible, making good points to take home. I think what is done has been quite of a sort of a information-packed ball of prolactin, possibly what he has given to all of us. And we are really thankful to him. And probably it has been one of the best conducted, knowledgeable, and best conducted RCME of the session till now. I thank everybody for joining us. Over to Dr. Tirthankar, please.
Yeah, thank you, Dr. Manu. And as you have already said, it's a very, very information-packed as well as very lucid. What I like most about Jagjot Bhai's presentation is very crisp, clear. His speech was also very audible and clear. Sometimes I find what's not there in some previous sessions, and it's very clear, crisp, to the point, accurate, and very information packed. So I find this is one of the best presentation. Hats off to you, Dr. Jagjot, and the time also didn't extend it much, and you finished it right on time within 40-45 minutes. I find a lot of questions, very informative session, and very nicely conducted by our two eminent chairpersons, Gulwar sir and Dr. Dipan, and Dr. Himabrata he conducted the session. It's very nicely. So I should congratulate everyone, and thank you to the Torrent team for the technical assistance. So I conclude the session for today. Thank you so much.
Good night, sir. Good night.
Thank you, everyone.
Thank you, everybody. Thank you. Thank
Bye-bye.
you.
Good night, sir. Good night, sir.
Good night.
Thank you.